Now I'm live. I am live, it says. So it helps if you push all the buttons, doesn't it? So, yeah, welcome. I'm Don Ridenauer. I'm a licensed mental health counselor in Indiana. And today we're going to talk about depression. And since the focus of my videos is everyday mental health, we're going to talk about how they affect real people, or how depression affects real people in their everyday lives, and then ways I have found working with clients that are effective in helping them relieve that depression. So first, I'm going to tell you a little bit about myself. I am, as I said, a licensed mental health counselor. I've been in private practice for just over 2 years. I did primarily DCS and probation work in people's homes for 2 years prior to that. And then the 2 years prior to that, I was a therapist in a prison for adolescent boys. I have been in social services and mental health for 30, 35 years. I was the director of a social service agency for 17 years, and that agency provided everything from therapy, where I supervised therapists for a while until I passed that along to someone else. We did financial counseling. We did a lot of at-home services through contracts with the state. And we did other programs as they arose, parenting programs, for instance. We sponsored the Child Abuse Prevention Council. And one of the things there are two things I'm really proud of. I'm proud of all that work, but two in particular. We had a domestic violence shelter that closed due to poor management. And we were able to take that over, reopen it, and it's been going ever since. And it's never had a day when there wasn't someone there. So I'm really happy with that. The other one is we brought a program into our community called Healthy Families, and it was part of Healthy Families Indiana and Healthy Families America. And that's a program that helps people who are struggling with learning how to parent and nurture and love babies and infants. It's for birth to 3, birth to 5. And it just developed and developed. There was such a need for it. So terrific program, great program, and one of the things I really like. So as you come in, make your presence known. I'm going to start talking about the signs and symptoms, and I'm going to take these from the Diagnostic and Statistical Manual, which is the mental health Bible, if you will. Let's see. This doesn't want to cooperate all of a sudden. Yeah, there we go. And so these are what every therapist, psychologist, psychiatrist uses to diagnose depression. These are the things we look for. And we tie them to how we see them in that person's life. Are these the things we're really seeing? And it just depends on how the particular therapist you are talking with or working with, or that you find to work with, approaches practice. So for instance, I do diagnose people. I have to, it's part of my job, but I don't really completely work from a diagnosis. What I work from is the behavior people are telling me is bothering them in their life. And then we look for the factors that go into that. How did that develop? And what can we do about it in everyday living to relieve the stress and strain and the dysfunction, move them towards a happier, healthier, more productive and rich life. On the other end of the spectrum, our psychiatrist uses those diagnoses pretty tightly because they help determine what class of medications are appropriate for that particular person. And then within that class, of course, there are usually a lot of options. So it really depends. And while I'm not totally diagnosis focused, I really do have to give an accurate diagnosis. And these are the things I look for. So I look for depressed mood, that feeling of sadness, of really being down, empty, hopeless, and worse than just a bad day or an off day. And so I'm looking for that most of the day, nearly every day. And that's from self-report of the person, or it's from the people around them have told them that they need to get some help. Next thing I'm looking for is a real decrease in their interest or in pleasure from the things they used to find pleasure in or were interesting to them. And again, nearly every day and most days. The next thing I'm looking for is weight loss or weight gain. And I don't mean a few pounds, I mean 20 pounds when they're not really trying to gain weight or lose weight. We're looking for a significant change. The other way it's often said is 5% of body mass. So either one, as a rough rule of thumb, I use about 20 pounds. And then the other part of that is appetite, a real decrease or a real increase in appetite. Someone who just cannot get full. They just eat and eat and eat, and they cannot get full, and they feel empty. And a lot of times that's called eating your emotions, or and it's a self-soothing kind of thing. But it's out of control when you have major depression. So, and then the opposite is obviously just never wanting to eat, having to force yourself to eat. That would be the other extreme of that. Again, with most of these things, it's either way too much or way not enough. So when it comes to sleep, same thing, either insomnia or what's called hyposomnia, which just means sleeping all the time. You just can't get out of bed. You stay there for 2 or 3 or 4 days at a time, rarely up, except when you have to. I've had people tell me they really only got up to occasionally go to the bathroom for 2 weeks, hardly ever eating anything. And then the other one is, as I mentioned, insomnia, and that is just staying awake for 2 or 3 days at a time, or barely sleeping, a few hours here, a few hours there, but nothing more than that. The next one is psychomotor agitation or retardation. Retardation in that sense means simply that slow movement, slow to react, slow to do anything. So on the one hand, you've got restlessness and agitation. On the other hand, you've got complete lethargy, unwillingness, inability to even move. So next one is fatigue, loss of energy nearly every day. Feel like you're dragging yourself around. So that's really common. Just wake up in the morning feeling exhausted, and it's all you can do to get out of bed and go do things. Often put things off and don't do them. That would be typical of major depression. Next is feelings of worthlessness or excessive or inappropriate guilt, even to the point of being delusional guilt. And I'll mention that in just a minute. And again, nearly every day. So worthlessness is just the kind of self-statements, oh, you're no good, you're just a burden to everybody, even gets to the point where it can begin to become suicidal ideation. Everybody would be better without me. I'm just a burden on everyone. I'm worthless. I'm not worth the air I breathe. That kind of thing. And I mentioned delusional guilt. That would be like there was a ship that sank in the Atlantic Ocean, and I was thinking about a ship sinking, and so it's my fault. I did that to all of them. That's delusional guilt. Not common at all. Typically, excessive guilt is something that really did happen, that you really didn't have control over, but you still feel very guilty. I run into this in grief sometimes where, well, like one kid told me recently that his mother had died and he felt terribly guilty because he stopped at her doorway and she was feeling badly and was in bed asleep. And he decided to let her sleep instead of telling her goodbye. And then he went off to school. And he believed, until we talked about it, he believed that if he had gone in and awakened her, he would have been able to save her life. And so it was his fault. That's typical guilt that we were able to work through and give him relief from that. Next thing is just a diminished ability to even think or concentrate, becoming very indecisive, just can't think clear enough to even make any decisions. That's pretty common. And then finally, the recurrent thoughts of death, fear of dying, but also suicidal ideation, but without a specific plan, or a suicide attempt or a specific plan. Any of the suicidal ideation, and the worse are attempts. So you probably just heard my dog bark. Hopefully it's not the mailman or you'll really hear him bark. So these have to be present for a 2-week period, and they have to be a change from normal functioning, so that there is definitely a difference, a change at the onset of a depressive episode. And there are 2 that have to be present, and that's depressed mood or loss of interest or pleasure. One or the other have to be present. And then there's a time factor that it goes on for a while, but that's just 2 weeks really. And this is major depression. There are other depressive disorders, and the one I will talk about is a persistent, I guess I didn't bring that up yet. Hang on a sec. So persistent depressive disorder used to be called dysthymia. This is a better, more descriptive title for it. The idea is that it's people who have been depressed for a long time at a kind of a low functioning state, steady state of being depressed. And so it's not diagnosed until it's been present for at least 2 years. And you have to have 2 or more of the following: either poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feeling of hopelessness. And by the way, with children and adolescents, the mood can be just irritable, and it only has to be for a year. So it's the mood part, being depressed, the hopelessness, all of that, and then any 2 of these 6 items. And I'm not sure if I mentioned it before, but out of the 9 or 10 items in major depressive disorder, 5 have to be present before it's diagnosed. So this is kind of a lower level of depression, but chronic. It goes on and on and on and on and on. And no action is really diagnosed unless it becomes problematic for the person. So it begins to interrupt their life. Either people tell them, you were really down too much of the time, you really need to go get help, or they start having trouble at work and they don't care. They start having trouble at home in their relationships, and they just are spending way too much time sleeping, not eating, not taking care of the house, not taking care of their family, that kind of thing, but just still getting by. Not like the total major depressive episode. And so the difference with this is that it's a persistent underlying disorder that permeates everything. Like major depression takes over everything, but this is still, people are sort of getting along with their life, but they're always down and they're always struggling. So let me clear my screen here a little bit so I can see if we've got any questions. I guess none so far. And so let's talk about some treatments. There are lots and lots of treatments. If you go on the government website, the Mental Health Administration or Mental Health Institute, what am I trying to say? The National Institute for Mental Health, there we go. Or SAMHSA, the Substance Abuse and Mental Health Administration. Websites, and you look at evidence-based treatments for depression, you'll just find a long list. But they come down to the two major ones, if you seek help, are going to be therapy and medication in one order or the other. The studies from quite a while back, I've never heard them be disputed since then, is that medication and therapy work best in combination. One without the other helps, both of them together are best. There's an interesting reason for that. The psychiatrist I work with mentioned recently that the medication provides a window of opportunity for people to address their real problems. And I really like that way of thinking about it, because for some depressions, yeah, probably lifetime antidepressant medications are going to be required where there's a real, some sort of biological base to that. But much more commonly are situations where there is just a situational reason for the depression feeding a tendency towards depression. And the medication provides that boost in energy, that lift in mood that gives people enough energy to then begin to be successful at therapy and to begin to regain some of their functioning in life. Same thing's true for the persistent depressive disorder as well. Therapy, what works in therapy? Well, there are all kinds of approaches that work well in therapy. You'll hear cognitive behavioral therapy, and that is the hottest one. There's been a ton of research on how effective it is. My career spans the beginning of cognitive-based therapy back in reality therapy and into positive self-talk and into the ABC model of emotional and behavioral control. I use all of those, and I use the CBT approach of really examining where does the thinking come from? What are the thoughts behind the hopelessness? What are the thoughts behind the I can't be here anymore, I can't stand this, I can't even get out of bed? And so, for instance, one person I know went to a new school, just could not cope, ended up not being able to get out of bed, failed all their classes, was in trouble. Actually, I could say there are several people, 2 or 3 of which I'm working with right now, that have a similar background. And so their life really starts to fall apart. And so they come see me, and I start examining, okay, well, yeah, that happened. And what were you thinking just before that? What was going on? Well, this was a lot harder than I thought, or people were not friendly. People were mean to me. People bullied me. And I just thought, it's going to be hopeless. I can't do anything about it, and there's no way out of it. And they spiraled into a deep depression. And so as I ask them about that thinking, I begin to ask them to examine the process. And that would be, well, I got my first set of grades back and they were all C's and D's. And I was shocked. I thought, sure, I would have A's and B's. Well, what did you think about that? Well, I thought I was a failure. Okay. And what did you do? Well, depending on age, I went out and got drunk. And then I just went home and just didn't get up, just went to bed, gave up. Okay. And so let's go back to the thinking. You see your grades, they're not what you expected. What's running through your mind? Well, I'm a disappointment. I'm a failure. I'm not good enough. And then we begin to challenge those beliefs. What do you mean you're not good enough? Well, obviously, my grades are good. Well, the C's in college level are passing. The D's in high school level are passing. So you're still passing your classes, right? Well, yeah, I am. So you're not as good as you want to be. You're not as good as you have been, but you're not failing either, right? Yeah. So this school is different. The teachers have different expectations. This was your first grading period, right? Right. So it's taking you a while to adjust to the higher standard, right? Well, I guess so. And so that was just your first opportunity to prove you could do it. So you've got another opportunity. And so on, and I build like that. This is a lot quicker than it would actually go with a real client, but you get the idea. So you challenge those thoughts and begin to produce some hope. And hope is the most important part of working with depressed people, because that's what they've really lost. At some point or another, they've lost hope. They've lost the ability to look ahead and see a future that is going to be good for them. They see nothing but the short term, and it's bleak. So that's how we start to work on it. You will also hear a lot about mindfulness and mindfulness meditation. That's a retread of transcendental meditation. But every so often, these ideas have to get rebranded so somebody can make money off of them. And so the current version is mindfulness meditation. And the idea is that you are paying attention while you're relaxing, while you're breathing, to only being here now. And there's even a book from the 70s, I believe. I don't remember the Indian author, but it was called Be Here Now. I think it was Ram Dass, but I'm not positive about that. Anyway, the idea is that you pay attention to your breathing. You feel and hear your breath go in and out. And anytime you begin to think about anything else, you just gently call yourself back. And then you work at that, and you spend 20 minutes a couple times a day, and you work on that. And it helps you gain presence instead of being stuck ruminating over past failures. That's helpful for many people. I also use a number of other dynamic techniques built in hypnosis and dynamic therapy and in problem-solving therapy. I combine all of that and talk to people at a deeper level of consciousness about their successes in the past, that this is a roadblock, that they're going to figure a way around, and I give them positive suggestions about that. Now, this is deeper than just positive suggestions. This is changing the way they understand themselves at a very deep level. So that's really interesting work, and it can be actually amazingly successful. Group therapy can work with the right leaders and the right commitment to the group by people. I don't hear too much about anybody doing groups like that anymore. Used to be more common. The groups that are run now tend to be more skills-based and more coping skills oriented. So I hear less about that. And so then there are other ways of changing a lifestyle that we know can help with depression. Exercise, just simply walking, especially with others, every day for 20 minutes, a half hour. Changing diet, smoothing out the diet, getting a more balanced diet. The problem with those is that when you're depressed, it's really hard to get yourself to do them. And that really is the trick with depression. When you are so depressed, you can hardly do anything. How do you do anything? And that's really the trick. And when people get so desperate, or their family gets so desperate, they bring them into treatment. And that's where the medicine and the early stages of therapy can help them regain some energy and enough hope to get them moving. Then exercise can come in later. But if you're in that chronically persistent kind of depressive state and you're trying to figure out what to do about it, you still have enough energy to go do things, then starting to do some moderate exercise. Doesn't have to be strenuous. You don't have to go spend a fortune on a gym membership and 10 new workout outfits. All you have to do is walk. All you have to do is park your car farther away, take the stairs, all those tips you know about already. And that will help you, but especially if you include some other people in it. You get the social interaction, and you'll also get some encouragement from them and some accountability. Yeah, I don't really want to go today, but they're expecting me, kind of a thing that helps. Anything to help get you going. Same way with the dieting, and dieting is not really a good word, but just better food choices. Reducing carbohydrates, for instance, that can tend to make us sluggish and bloated and all of that. So those things you can add on when your depression is mild and you just want to lift your spirits. The serious depression, where you really can't get going, you really pretty much have to start with the medication and therapy to get your energy up to the point where you can do the other things. So that would be the order. The other thing I want to talk about just for a second is self-talk. And that is, we all have this internal dialogue going all the time. We talk to ourselves. Some of us talk out loud when nobody else is around, or at least when we think nobody else is around. And we have this constant dialogue. A lot of theories about that, and it depends on what yours is, but most people who are depressed have a very critical self-dialogue. Oh, you idiot, you screwed up again, you dummy. And it gets very profane. They call themselves terrible names and put themselves down, and you'll never amount to anything. And before long, well, it develops early, and one of the theories is that that's really your critical parent that's doing all of that talking. You have internalized all the criticism that a parent figure gave you, and now that's what you hear in your head. Well, that can change, and you can very deliberately begin to say, okay, I got this. I can do this. I know I messed it up before, but look what I learned from messing it up. I learned more from my failures than I do from my successes, so I'm going to take those as times I learn things, and this time I'll do better because I know those things. So I can do this. You're worthwhile. I'm worthwhile. You can do it. And you talk to yourself like that. And you begin to make a habit of that anytime you catch the negative dialogue going on. You just go, stop. And you flip it around to the positive self-talk. And you begin to make a habit of that. And it's pretty amazing how much effect that can have on you. So give that a try if this is your issue or one of your issues. So give it a try. See how it works for you. So that is the overview of depression and what to do about it. And now we'll consider a couple of questions. One question is, where do I go to get help? Well, the best thing to do, well, actually, there are several ways to find help. One, you can ask your family doctor, and they will give you some referrals. If you don't have a family doctor or it's taken too long to get in, whatever, you can call 211. That's just the 3 numbers on your phone, 211. And in most areas now, that gets you to an information and referral line that can give you some mental health referrals. The other thing to do is Google it. You Google everything else, Google mental health help in my area or near me, and see what comes up. Now, what's going to come up are the major hospitals and a bunch of practices. And all of those may be really good. You can go through and read the reviews. And if there are a few negative reviews, don't worry about it. None of us can make everybody happy. So just look for the best reviews and then go make that call, which is the hardest part. And I always commend my new clients for having the courage to actually walk in the office, because I know it does take courage. And I just appreciate them being willing to step out like that, out of their comfort zone. So those are the best ways to find the providers in your area. And then it's just a matter of making calls, seeing who can get you in the soonest, and from their profiles, who seems like a good match. Hard to tell. Once you get in face to face, decide, is that somebody I can work with, and do they have a successful track record for dealing with my kind of problem? And you ask those questions. I would also recommend that you only go to a therapist that has psychiatric backup. And that's so that in case you do need medication, he's got some place to get you in, because it can take a couple of months easy to get in to see a psychiatrist pretty much everywhere, and even longer at times. Your family doctor may be willing to give you some, in fact, they're probably more than willing to give you an antidepressant medication. But the thing I run into over and over and over again is that because they're not specialists in mental health, they tend to under-medicate when it comes to anxiety and depression. Excuse me. So even if you get an antidepressant from your family doc, ask for that referral, and find a therapist and a psychiatrist and let them manage it, because it may take a higher dosage to get you moving, and then the therapy to sustain that direction, that improvement, that you won't get from your primary care physician, no matter how good they are. That's not the issue. I think that answers that question. Another one is, you talk about psychiatrists, you talk about therapists. Are you a doctor? No, I'm not a doctor. I'm a master's level mental health counselor licensed in Indiana, and I cannot prescribe medication, and I can't do psychological testing. So another mental health professional is a psychologist. They primarily do testing of one sort or another. The hot area is neuropsychological testing. And then there's just general psychological testing, which actually is a lot more helpful when you're doing therapy than I've ever found the neuropsychological reports to be. And then there's a psychiatrist. Psychiatrists are medical doctors. They've been through med school, they've done their residencies, and they've focused on mental health and mental illness issues. And so they're the ones who can medicate. They're the ones who know the different medications, the different reactions, the chemical structure, all that kind of stuff. And they're the ones who should manage mental health medications because they're the specialists. They're the ones that are trained for that. Another question is, how long is this going to take? And that is a very good question. And it's only fair for people to be able to have some idea of what it's going to cost. Now, of course, each practice is going to set its own fees, but all of the actual charges are going to end up being controlled by insurance companies or Medicaid, Medicare. So each practice gets reimbursed by the fees that the insurance companies or Medicaid, Medicare pays them. And each one of those has their own rules about how much you would have to pay out of pocket, what the deductible might be per session. And then, of course, with insurance, it's going to be until your deductible is fully met, and then something else may happen, or you may always have a certain amount you have to pay depending on your policy. So I've seen copays go from nothing to $35, $45. Just depends on the insurance. If you have no insurance, then you're going to expect to pay somewhere between $75 and $150 per hour for the service, or per session, I should say, for the service. So, and then it's how many times? Well, you can plan on 2 times just to do intake and understanding of your problem. If you feel like your therapist doesn't get it after 2 sessions, ask them, how do you see me? Where do you see this going? And how long, how much time do you think it's going to take? And they're going to be pretty iffy about that because it's hard to predict. They don't know you very well yet, but they should be able to say, well, this is what I think the problem is. You clearly have a severe depression and you're going to need some medication for that. That's going to take a month, 6 weeks to get you in and get the medication started, unless your primary care physician will start it. Meanwhile, you and I will be working on the issues in your life and the way you think. And just depending on how we connect on that and your responsiveness to the various things I know how to do, it may take anywhere from 6 to 12 sessions. And so then you just do the math and you know about how much it's going to cost. Typically, we only get 12, 15 sessions per year to help our clients. And it really varies. Some people are going to respond pretty fast, and some people, it's going to take them longer to work through those things. And, it's not always the severity of it. I've had people recover from terrible trauma in 6 sessions. I've had people that have had severe trauma that we're working on two years later. So it can really vary. And that's why we have such a hard time telling people how long it's going to take. So the therapist is only going to give you a general idea of that. And that honestly is the best we can do. Unfortunately, there's a federal law, or fortunately, depending on how you look at it, federal law went into effect on January 1st, where if you have no insurance, you have to get, or I should say, you have the right to get, and we have to give an estimate, including how much it's going to cost to get the diagnosis and then the treatment. We can't really do that because we don't know until after we've done the diagnosis what the issue is going to be. And like I said, that's going to take a couple of sessions, maybe 3. So I think the way we're still, and by the way, the profession's still working all of this out, but we think we can just say, well, it's going to cost you this much to get the diagnosis and then we'll give you an estimate for your course of treatment. And apparently that is going to be acceptable. Honestly, otherwise I don't know how we're going to do it. But that's the approach we're working with right now. It's all brand new. We're working on it. So in terms of length of time, I think you're looking at weekly. I wouldn't ever start a new client if I couldn't see them every 2 weeks. Other therapists, other clinics have different views on that. I really don't like it in the profession when someone comes in, does an intake session, and their next visit is 6-8 weeks away. That's just not effective. I would rather have someone wait to start and then start every week or 2 weeks and work with them that way than I would have them come in and then not see them again for 6 weeks, and then maybe not for 3 weeks, and 5 weeks. That's just not, you can't do effective therapy that way, in my opinion. So I would really question that if that's going to be the situation. And if it were me personally, I would find a different provider. Depending on the choices available to you, may or may not be able to find another provider, and something's better than nothing sometimes. So that's a long answer to how long is it going to take. And unfortunately, there's not a short answer to that. I'm going to take one more question, and then we'll wrap it up. And let's see. Oh, if you know someone who's really depressed and they are not wanting to get help, what can you do? That's really difficult. If you're a parent and it's one of your kids, you just drag them, right? I mean, that's just what you do. If it's a friend and you don't have that kind of leverage, you really just have to say, look, I've done everything I know how to do to help you, to encourage you, and I really think you need more. And you just do your very best to convince them. You even help them find a provider, or even get a recommendation for a provider and offer to go with them. Probably just to the waiting room, but at least you're there with them and you give them that moral support they need to actually get in the door. And hopefully that will be enough to get them moving. You just do your best. That's all you can do. If it's a parent, really, you may or may not have the leverage to make them go. So use what you've got. Go with them to their family doc appointment, and then tell the family doc what all's going on and that you're really concerned about them and feel like they really need some therapy, and where could you go, and would he recommend that to your parent? And sometimes they'll go when the doc tells them to. So that's a possibility. Can work with friends too, I guess. Friends, I think you just pretty much have to persuade them. That's a tough one, because you see somebody suffering and you want to help, and it's your friend or your family member, and you really want to help, and you truly believe they need the help, and they just won't do it. And then you might begin to question them about, you really want to live this way? You really want to go on? You really want to, treatment works. It helps people every day. People are getting better. Depression is very treatable. So why would you want to keep feeling like this when you could feel better? And help them build some motivation within themselves that way. This is kind of true of spouses too. I mean, you can't just keep nagging and nagging and nagging, because then they just dig in their heels and they won't go. But you can encourage them. Honey, I'm really concerned about you. I think you're just spending way too much time in bed. I think you're spending way too much time being sad. Let's go see the doctor and see what he recommends. Or we talked about therapy before, and I think now would be a really good time to go. Let's go. And you do that. So you do everything you can do. And a lot of times you will be successful. And then you just hope they engage well right at the beginning. So that they will keep going and that they will start finding relief. Because once they find relief, then they've got a choice, right? They can either feel better or they can go back to the way they were. And most people actually like to feel better, and so they will continue. Okay, that wraps up the questions. So what I want to do now is just summarize a little bit and just say depression is very common. It's very treatable. There's no reason to go along suffering and suffering and suffering when there's help out there and there's effective help out there. So if you've really been struggling with it, you've tried a bunch of stuff, but you can't keep going at it, you just don't have the motivation or you don't see the results you're looking for, then find a therapist that has psychiatric backup and begin to make your life better. So glad you joined us. If you enjoyed this live stream, it'll be up as a recording. You can like it. You can follow me. And I appreciate your support. Thank you very much.